My goodness, what an intro. I feel so exposed. Part of that was true, the part about me posing nude, and I'm assured that it will be tastefully nude, as the art directors of the calendar have explained. The part about me stripping here at this talk, that was drawn from my other line of work, which is fiction. Now, I'm a writer and an emergency physician, and thank you very much for being here to hear a writer and an emergency physician, not an academic expert in the area of quality, at the end of a long day. And so I certainly appreciate your ongoing interest and attentiveness. Now, every good self-respecting talk I've discovered begins with a disclosure of conflicts of interest. And usually this is how it goes at a physician's conference. Someone comes up and says, look, I'm going to talk about this drug or this procedure or what have you, and just so you know, I have a few conflicts of interest, and then up come a long list of affiliations and consultancies and this, that, and the other. And then everyone in the room thinks, man, so that's how he or she can afford that car. That's incredible. So I don't have any industry conflicts of interest, but I just want to put it out there that if anyone here wants to suggest any, they can talk to me later. I'm open to some sort of reasonable conflict of interest, although I have none at present. Most good talks also begin with some sort of disclaimer. And as I've already said, one disclaimer I'll make is that I'm not an academic expert in the area of quality, but what I think is that all of us are experts and need to be experts in what creates high quality care and high quality work in the work that we do. And then the other disclaimer that I'll make is that I always suspect that when people see titles which include things like narrative and stories, they're expecting a feel-good talk. Now, I have very little control over whether you feel good at the end of this talk or not. But what I'm aiming to do, and if you feel good, that's allowed, but I'm aiming to challenge you a little bit on issues of narrative and issues of quality. And so I'm going to talk about a few cases that raise some difficult questions, that raised some difficult questions for me as a clinician. And I think that if we are looking for easy answers, we won't easily find them. But I do know that narrative helps me a great deal in approaching quality in my work. And note I say approaching, which is very important because I think we are continuously on a path approaching quality. Now, why is it that we do what we do? There's a lot of us in this room, and hopefully we're not all at it because it's a simple operation, routine, boring, only doing it for the money. I hope not, in any case. Now, I know there's a huge range of people. There are people who look at the big picture in this room, academics, administrators, and there are people who come at this from a clinical perspective, who work at the bedside like I do. And I think that there are many people who do a bit of both, who do some clinical work and who also aim to make systems better. And so what do we have in common? I hope it's not this. I think that what we have in common is that we care about quality, and quality is not necessarily easy to achieve. It's also not routine and not boring. In fact, I think it's part of what keeps healthcare from being routine and boring, that we care about making it better. And for me, another thing which keeps healthcare from being routine and boring is that I care about people's stories. And often, people's stories are part of what keeps me coming back to my work every day, interested in what is going on with people. It's a big part of what guides me through difficult situations, and I think helps me to approach quality. So, a few cases. Case one. And just so you know, we love to do this as physicians. You know, we show cases and we show all sorts of numbers and data and blood gases and ECGs, and there's always some trick, right? There's always some innocuous seeming ECG, which in fact pretends some terrible ha-ha-ha diagnosis, and the presenter just loves it when when no one can guess what that is. And I'm not doing that today. In fact, today I'm not going to present any numbers or vital signs because it's not exactly what I'm trying to get at. Case 1. Patient is an 81-year-old South Asian woman. History of present illness, unable to sleep, felt panicked last night, unwell this morning, no pain, but woke up this morning and asked her family to bring her to the emergency department where I saw her as one of the first patients on my early morning shift. Other stuff we know. Now, this is not typically the way a medical history is presented. But I think it's very important because I think this is actually often how the mental process works. We know who the patient is. We know more or less what the medical issues are, the ones that come straight at us, and there's a bunch of other stuff that we know. We have to figure that out. So this 81-year-old woman, patient number 1, has had a 3-month history of exertional chest pain suggestive of coronary artery disease. She's got diabetes, she's got high blood pressure, she's got high cholesterol. Interestingly, this issue has recently been investigated. She was sent for a cardiac workup. They tried to do the stress test, which, as you know, involves a treadmill. She has bad knees, some back pain, couldn't quite meet the target heart rate on the stress test, was told, no problem, you'll come back, we'll get a percentine scan on you today. And so her family is quite concerned. Her family says, doctor, you know, this is very important. She's got to have this test. And, you know, doctor, in fact, this is the 3rd time this test has been scheduled. Oh, okay, that's sort of interesting. So that brings us to another element which is not a standard element of the typical medical history, but which I think helps me a great deal. I hope will help you, and I hope will help you to approach quality. And sometimes when something is sounding a little bit funny in the story, I ask myself, wait a minute, what exactly is the story? And this requires stepping back, taking a moment, and asking in whatever language seems most appropriate in that time and space, whether it's an open-ended question or whether it probes a little bit, a question that opens up the story. And so in this case, I asked this patient, so, wow, I mean, this is the 3rd time this has been scheduled, this percentine scan. Yes. And the family is answering already. The family is jumping in. The family is saying, yes, you know, this has happened a few times before, and the cardiologist says she must have the test. You know, every night before the test, she can't sleep. She feels absolutely terrible. She completely freaks out, and then early in the morning, she calls us and says, I have to go to the hospital, and we end up here. No test. Oh, well, this is sort of interesting. This is sort of an interesting story. I'm not really sure what's going on. And so one thing that I notice in this interaction is that my patient's English abilities are somewhat limited. In fact, every question that I ask her is answered by the family. The family jumps in, tells me exactly what's going on. Very attentive, very loving, very caring family. And I also notice that sometimes I ask the question, and the answer comes back to me. You know, it's a direct question to the patient. The answer comes back to me without any consultation with the patient. I'm sure you've all experienced this. Someone knows the answer already and doesn't feel the need to inquire any further of the person to whom the question is posed because they already have the story. So I say, you know, please, Mr. So-and-so, if you wouldn't mind, could you just ask your mother, just ask her, why is it that she's afraid of the test? And I've taken a certain leap here. No one has told me that she's afraid of the test. In fact, I've sort of made an inference, and that's part of the narrative exercise. Sometimes it's necessary to make a little bit of a leap, and the answer comes back, and the family is actually a little bit sheepish explaining this to me, and the answer comes back, well, you know, she's very concerned that the test will tell her that she cannot go back to India. I say, oh, well I'm not sure, wait, I have to look up my medical textbook, percentine, Are there percentine tests which indicate that one cannot travel to India? I think probably not. I can't find it anywhere. But as it unfolds, the family's telling her, no, you have to have this test, you have to have this test. And the cardiologist is telling her, listen, you have to have this test, and I absolutely can't clear you to do anything, to go anywhere until you have this test. You've got to get your cardiac workup. Third time this has been booked. Patient finally says, yes, doctor, I am scared of the test because I really want to go back. So here are a few quality options, right? And one of the things that I find most interesting about trying to deliver high quality care is that, guess what? There are many things which define high quality care. And sometimes they are in conflict. And so quality option A, and what I'm going to do, especially because this is the end of the day, and I won't make you stand to do this, but I'm going to get people to vote on the option which they think is most suitable and which achieves the highest standard of quality. All right, so option A, this is the standard of care. This is a woman who has a history of pain which is very suggestive of coronary artery disease. She really hasn't been worked up properly. We don't really know exactly what's going on. She must do what her cardiologist says because that's the standard of care, and we know that that's the professional expectation that the cardiologist would have and that I should have of her care in this situation. Option B, and this is what one of her sons says. Look, Mom, we're in Canada. You have the best quality health care in the world. Debatable, I know. Just go with it. Accept that for the moment. You cannot go back to India. Absolutely not. There's absolutely no way. Because why would you do that, Mom? I mean, we are in Canada. This is the best quality healthcare. What are you going to do if something goes wrong in India? Sort of murmurs to me, Doctor, do you have any idea how much health insurance will cost if I try to buy health insurance for her to go traveling to India? Which is true. I mean, this is a real issue. I've looked into this with my own family, and it's expensive. Option C, quality communication to weigh options. All right, so who votes for A? Not many takers for A. B? No. I should have concealed C. This is far too easy. Don't worry, the cases will become far more difficult as we go along. This is the other trick in medical presentations. It always starts easy. Quality communication. How many people go for C? Excellent. Which is indeed the course of communication which we pursued. And I said to her, and I said to the family first, I said, look, I'm going to tell you some things that maybe no doctor has told you before, and if you wouldn't mind, just tell her directly because I think it will help you and it will help her. And I said, look, there's no test in the world which will prevent you from traveling anywhere. But what you do have to understand is that you likely have a disease which carries certain risks. From what you're telling me, it's very likely that you do have coronary artery disease. But those risks exist here, and they exist in India, and they exist anywhere that you go. Your treatment options may be different depending on where you go. And so I said to the family, if she really wants to go to India, you have to understand, and these are the exact words that I used, that at any moment, even if her risks are perfectly optimized, she could have a heart attack and die right here, 3 blocks from here, at your home. You wouldn't believe how happy the family was to hear that. And I didn't take it the wrong way, and I don't think that they had any malicious intent. But what that information did, what the high quality communication of options did for them, was it freed them, right? They thought that they were shackled by this notion that, no, she's got to be here, she's got to be with the best doctors, being very good children. Of course, they wanted the best thing for their mother, and they felt the best thing for their mother was what she was able to receive right here in Canada. And so it would be unfaithful, unfilial of them to tell her that she should do anything which might slightly increase her risk of having some sort of adverse outcome in a setting which she might not, in which she might not be able to receive the same care that she would be able to receive at home. And so freeing them from that and saying, you know what, Life is about what's important to her. If she wants to go to India and she understands these are the issues and these are the risks, then she should go. And she should probably have the Prasanthi, but it really doesn't make a difference in terms of that fundamental decision. If she has it, then wonderful, she can go. If she has it and she has a good result or a bad result, she can still go. It's a question of making the decision. And I think what this speaks to is an insight of Jerome Grootman, which is that statistics cannot substitute for the human being before you. They embody averages, not individuals. We may know what the standard of care is for anyone with suggestive quality of chest pain, and yet that may not be forefront of mind for every single person. Case number 2, it's just a little cut. This sounds like an easy case, right? All right, so patient, 18-month-old boy, comes in, well, brought by his mother, since 18-month-old boys don't generally come into the emergency department on their own. I don't know if any of you have had an 18-month-old child, but you will not be surprised to learn that this particular 18-month-old child was running, jumping, dancing, crashed into a coffee table, and had a laceration just here, right? Very small. Not a globe penetration, not a vision-threatening injury, no sign of a major head injury, happy, alert, actually totally out of control child holding a big bag of cheesies. Cheesy crumbs all over the place. Happy, happy, happy. Mom, not so happy. First words being, "Oh my God, I've been here for hours. What's wrong with you people? Are you a hospital?" I'm sure none of you have ever heard that in the setting in which you work, in which everyone is seen in less than 3 or 4 minutes, right? So this seems like a fairly simple case. Kid's got a cut. Yeah, right. I don't know if you've had this insight. I have small children. Nothing is simple with small children. Yes? So this particular cut is right here, very near the eye, easily fixable, and you or I would just say, you know, hold still. I'm going to fix your cut. I might use some anesthetic if we're friends. But in this child, it will not be safe because the child will be moving. You can secure the head to some degree and have a screaming, hysterical, terrified child, which is a terrible quality of care. But in this case, even doing that will not assure me that I can actually appropriately close this laceration without poking a hole in the kid's eye. That's a bad quality outcome. So I tell the mom, okay, this is fine, you know, we can totally fix this. Your child will require a sedation, just a little bit of medication. I explained to her some of the risks involved in that, and we'll just make him sleepy. He might be a little bit crazy, all this kind of stuff, as if he's not crazy enough. Listen, it's just that his stomach has to be empty, and at this point, he has just had a whole bunch of cheesies. And yes, I want him out of here just like you do, because he's destroying the playroom of the hospital. And yes, I know it's way past his bedtime, but I can't put him to sleep right now because there's cheesies all over his face, and he's holding the bag, and I know that he's just been eating cheesies. Okay. The response: is this an emergency department? It's your fault. I've been waiting for hours. No one told me not to feed him. Oh, her gender dislocation. I try to alter these things to protect identity, but I'm sometimes a little bit amorphous on that. You expect me not to feed my child. I'm raising her on my own. Do you know how tough that is? I haven't had a good night's sleep in months. And then it begins, you are a bleeping hole. What am I supposed to do for 3 hours? Patient is laughing hysterically. Totally uncontrollable. And I mean, you have to understand, right? I have 3 kids, aged 8, 5, and 2. Essentially, I go to the hospital to get a break from my kids. And here I am thinking, I do understand, lady, but I just, there's nothing else I can do. I cannot, in good conscience, put your kid to sleep with a stomach that is very recently full of cheesies. And I'm sure many of you will understand that the issue there is there's a risk that the child may vomit in the midst of the sedation. The vomiting may end up resulting in an aspiration. An aspiration can lead to pneumonia and other serious life-threatening consequences. And that would be a real shame for a little tiny eensy-weensy cut. The story continues, it gets worse. You bleep head, you bleeping, racial slur, you can't maybe wait around, blah, blah, blah. I mean, you know, this part happens to me all the time. It's the part of having to deal with kids just like my own that I resent, right? I don't mind the name calling, that's okay. Mother leaves with child. Now, thankfully, I work in a team environment where everyone is really supportive and everyone's kind of rooting for each other and trying to achieve the best quality outcomes. And to this end, a very observant nursing colleague of mine says, "That's a mom on the edge." Physician colleague, "Nicely done." You see, it's all about support, right? Whatever happens, things aren't going well, you know, just big pat on the back. Well done, that was great. Very nicely done. All right, so quality options. And so, you know, literally I'm sort of watching the mom leave and thinking, oh God, my shift was supposed to be over. I want to go home just like she's going home. And so here are some quality options. And one thing that, of course, any clinician who takes care of children must think about is, well, you know, I have a duty of care to the child. Is the standard of care in this situation that I call children's aid services? And say, you know, I really wanted to fix this cut properly. I've got to talk to you guys. Option B, mom-centered care. Let the kid have a scar. And between these two, it's a little bit tricky. And it has to do with what we care about in the story. Because this is not a globe-threatening injury. This is not an injury which will leave the child impaired in some way. This is an injury which, if not repaired, will result in a slightly larger, possibly unsightly scar. Is that a big deal? Well, I don't know. It depends on what matters to a particular person in the story. Does it matter to the mom? I'm not really sure right now because she's really pissed off at me. Does it matter to the kid? Well, I have no idea. Is the kid going to be denied an incredibly lucrative modeling contract at some point because of this scar? Or maybe actually the scar will do the kid a world of good because it'll sort of be a heads up, you know, one foot up on the ladder of professional hockey. Now, option C, quality companionship. Work together, teamwork. I'll take my helpful and supportive colleague aside. Come on, tell me what you would do. Tell me what you would do. Give me some advice here. I'll document it. I'll make sure it's in the chart. We can all go to court together. Right? You know that when they sue everyone whose name is on the chart. Right? So you want to have as many names as possible. You can charter a bus and all go to the court together. Okay, so who votes for option A? Not too many takers for CAS. And I have to tell you, I thought about CAS long and hard, right? And part of the problem was that I couldn't really convince myself that there was an actual neglect from the mom's point of view. I mean, the kid was well fed, well kept, mom was very upset. Was the kid really being neglected? I couldn't really say the kid was being neglected. Was it that the kid was being abused. Certainly not. The kid ran into a coffee table. And furthermore, what good would it do? By the time CAS, I've called CAS before, and God love the people at CAS, Children's Aid Services. I don't know if you have a different acronym here in British Columbia. But I find that there's a lot of paperwork to be done. I don't know if that happens in any other healthcare system. But when I call CAS, there's a lot of demographic information. There's a lot of this and that and the other. And I'm pretty sure this child is not going to get back to me in time for me to actually fix this cut in the appropriate time frame in any case. So how many people will go for B, mom-centered care, let the kid go, have a scar? A lot of takers. Okay. Yeah, and I think that's a very reasonable story to buy, right? You don't buy the narrative of the tiny little scar being such a big deal. How many people vote for quality companionship? You see, you guys are such team players. So nice. No one would believe, or no one would admit to doing that. I went for option C. Kind of. So I asked my colleague who truly did say nicely done and got a great deal of humor value out of my predicament, and who also happens to be a wise sort of beatific figure in emergency medicine who started practicing the same year I was born. I kid you not. I asked him what he would do, and he said, look, give it some time, wait for mom to get home, and then call her. And first thing you say is, I'm really, really sorry, Mrs. So-and-so. You must be terribly frustrated, but, et cetera, et cetera. So I said, okay, that's a reasonable plan. I'll do that. That's a good plan. I continued my shift, tried to call her 15 minutes later, half an hour later, an hour later, and by this point I'm about 2 hours beyond the end of my shift, which is sort of normal, but it's time for me to go home. And so I say to my helpful colleague, listen, I haven't been able to get here. That was such a great idea. Would you mind calling her? That was an amazing idea. And so he sighed and he did it, right? And so I saw him a few days later and I said, oh, whatever happened to that kid? And he said, yes, shortly after you left, I called her and she brought the kid back, and mom was hysterical and screaming at me after a short period of time, and kid was hysterical the whole time. It was one of the worst experiences of my life. But the cut was closed perfectly. So there you go. So that's a high quality outcome if there ever was one. This may be what your emergency department or your hospital feels like at times. Now we heard a great keynote this morning, which I really thought was great, and it was and one of the fascinating things was the discussion of what services you can provide to generate additional revenue streams. And we don't have the same kind of flexibility in the Canadian system, but this would be an option. Right? Sell a few raffle tickets. Case number 3. And this is a real case. These are all real cases. And like all cases, it starts off sounding fairly straightforward. A 67-year-old woman brought in unconscious, unsteady on her feet for several weeks, say the family, not seen, in fact, for several days, and today found unresponsive. Last night they thought that she was especially unwell, and she had been sort of bedbound, in fact, for a couple of days, but they went down to see her today, and she was unresponsive. In the ER with agonal respirations. I asked, has she been having breathing difficulty for a while? And they said, yes, for the past couple of days. And I asked, tell me about her being unsteady. Was she sort of, leaning to one side, or what was going on? They said, yeah, I think she was leaning to the right side, and she was sort of stumbling around a little bit. Not a very reassuring clinical picture at all. In fact, my first thought when I saw this woman was this is a woman who needs aggressive intervention. This is a woman whom I'm going to be intubating in a few minutes from now, otherwise she's going to die. That was my first thought upon seeing this woman. And any of you who have worked in emergency medicine or critical care know that you can make that assessment fairly quickly. It's a simple assessment that someone is critically ill and near death. Other stuff we know. So I'm not going to bore you with her vitals and all the rest of it. I'll say that they were terrible. Terrible oxygen saturation, low blood pressure, clearly a very sick woman. Other stuff we know, she's been living in the basement of a relative's home, that her life really, really changed within the past year because her husband died of metastatic lung cancer. She wasn't able to stay in the home where she had been living with her husband, and so it was necessary for her to move into the basement of a relative's home, which is why they were sort of aware of what had been going on with her, but because they wanted to give her her own space, they weren't always there with her all the time and couldn't furnish some of the details about what had been happening in the past few days. What's the story? So the medical assessment, from my point of view, was that this was a critically ill woman, clearly close to the end of her life without aggressive resuscitation. And I put it together in this way. I thought, well, you know what? This business of sort of stumbling to one side, she probably had a stroke. She had some sort of hemiparesis. She was unable to ambulate. She was unable to control and protect her airway. At some point, she aspirated, and now she has an aspiration pneumonia. And so I explained this to the family, and I said, you know, she's really sick. This is what we're going to have to do. I'm going to move her to the resuscitation area. We're going to give her a breathing tube, and we'll see what we can do. But she's very, very sick, and I have to be honest with you, she may not make it. Family says, doctor, she saw what her husband went through. She said she never wanted life support. Now, I know that we often have a discussion around this topic. And I know that often we raise the issue when we don't feel that it would be useful or beneficial for someone to receive the most aggressive forms of treatment. And we say, you know, they've had a long life. This is the story of their illness. We don't feel that we can really offer a great deal of benefit through aggressive interventional measures. We recommend that you don't pursue this. We recommend that we keep this person comfortable and treat them through other means. That's the more frequent conversation. This conversation happens a little bit less frequently. It does come up once in a while, but it happens a little bit less frequently when we think, you know what, this person needs aggressive treatment, and the family says, no, the patient said that he or she would not want aggressive resuscitation. And that has to be respected. That has to be given serious consideration. Because we're talking about what people would have wanted if they had been able to speak for themselves. Now, the other thing that plays into this is the reality that we're all under immense resource pressures. And I have to say, although we may not ever try to dissuade someone from necessary services, when someone doesn't want services which we think medically they should have, but which as a system we are strained to the point of bursting in order to deliver, we say, inside, few. It's an uncomfortable thing, but I think it's true. In many care settings, we say, 5 minutes ago, I was thinking about my resuscitation bay, which was full, no bays available. I was thinking about who I could move, how I could get this woman in there in order to be able to intubate her, give her pressors. Now, That's not my problem anymore. This is a crowded place. All right, next patient. So her sister, who was there, said, well, you know what, it's time. She had a long life. This is the end of her story. It's time. Pulled out the cell phone, started calling family members, saying, you know what, I have some really terrible news, but if you want to say goodbye, you should come. And so I explained to the family, we're going to do everything possible to keep her comfortable. Are you absolutely sure that you don't want aggressive measures? Because that is what we would do. And the sister says, no, absolutely not. She says that she would not want life support. She would not want to be in the situation that her husband was in. She saw him languish, and it was absolutely terrible. And she said very clearly she would never want to be placed in that situation. All right. And I have to say that my assessment of the situation was relatively grim. She had a meaningful stroke, enough to impair her airway reflexes. I didn't know how long. She had been hypoxic. It could have been for a very long time. Outcome at best, arguably poor. Lots of family coming. They all live in the GTA. Lots of family coming to say goodbye to their auntie, who's not really very responsive to them. And we didn't really do anything aggressive for several hours. We let her stay in a quiet, peaceful place in the emergency department where her family was able to be with her and to be able to say their goodbyes. And this seemed like the highest quality thing to do, given her wishes. And so towards the end of my shift, honestly, I thought that she would pass away before the end of my shift. She appeared that ill. And the end of my shift came, and we don't tend to hand over patients in this situation in the department. If it seems that they're going to require some sort of attendance for a period of time, we refer them to the internal medicine service. I spoke to the internal medicine physician, explained the situation to him, explained the family's wishes. He was happy to see her. He went to see her, and then he came and approached me about half an hour later, an excellent internist, really a great, great guy. And he said, Vincent, I just want to see what you think about something. Right? Now that can mean a whole lot of different things when someone says, I just want to see what you think about something. It could mean that they just want to see what I think about something. I'm thinking about whether to have a turkey sandwich or roast beef, and I just wanted to get your 2 cents worth, right? That's possible. Or it could be, Vincent, you've totally messed up. What the heck are you doing? But because I'm a really nice guy, I want to bring this up in the nicest possible way. Of course, the fact that I'm so nice makes you feel even more terrible, but that's what it is. So that's the option. You totally missed the boat. I'd like to point it out in the nicest possible way. The upshot of which is this is going to be tricky. So my colleague flipped up the chest X-ray, and these days it's all digital. You just click and there it goes. And he says, what do you think? I said, well, she's got, a great big right-sided pneumonia. I think she probably aspirated. And my colleague said, well, I don't know. I mean, this might actually be a pleural-based collection. What do you think? Do you think it could be an empyema? And I realized there's clinicians here and non-clinicians. And so the distinction between what I saw and what he saw was that I thought, there's probably a big chunk of fluid sitting right inside the lung. And what he saw is, I think there might be a big chunk of fluid sitting right outside the lung. And this is an important distinction because the second can be drained. I looked at it, I said, you know what? I think you're right. And, I'm pointing out this case for a few reasons, and one of the reasons that I'm pointing it out is to say that sometimes we can become fixed upon a certain narrative, and that narrative can lead us astray. And I think in this case, I had come to what seemed like a reasonable explanation. This person had a stroke, aspirated, and now had a very poor prognosis. There wasn't much we could do, although we could try. And I had been relieved that the family didn't want this. And so a second look at the same chest x-ray arrived at a different narrative, which was that, you know what, maybe there is something we can do. And of course, we're looking at this here on the monitor. There's about 10 relatives over there, all saying tearful, heartfelt, loving goodbyes, expecting at any moment that their beloved relative will pass away. A little bit uncomfortable. The options, now medically speaking, intubation could still be an option, right? Although really the patient seemed to have indicated quite clearly that she didn't want that. The internist said, well, you know, is it possible that maybe if we put in a chest tube and we drained the fluid and got some fluid back and saw her SAT coming up, maybe we could put her on BiPAP if she needs it. Maybe that's not life support, or maybe it is life support. So this, as I said, the cases are getting a little bit more tricky. So I'm going to give you a moment to reflect upon it. Meanwhile, I'm going to ask you why it is that we don't have a healthcare system composed entirely of specialists. And as you can see, these patients have been extremely cooperative because they've assorted themselves to the right doctor with their eye, ear, nose, and throat problems. But as you know, real patients in the real healthcare system don't assort themselves so neatly. They come with a story which goes like this. I had pain in my ear, which radiated into my toe. Then that caused my entire body to break out in a rash. I started seeing things. And if you could fix me in the next 10 minutes, because I have my favorite television show to catch, I would really appreciate that, doctor. That's the actual healthcare system. And so people bring an undifferentiated narrative. And our job is to work out what that narrative is, what that narrative means, and what exactly we intend to do about it. Now, on a slightly more serious note, this woman came with an undifferentiated narrative. I came up with a certain narrative. My colleague, my internist colleague, came up with another narrative. And so, what are our quality options? Now, we certainly live in an era in which I think no one misunderstands the importance of patients' wishes. And so one option is to stick to the advanced care directives, no further aggressive measures. That's what the patient said. The one wrinkle in that is context. And here again, narrative is extremely important. When we sort of unpack what the patient said was that she didn't want to go through what her husband went through. Her husband had metastatic lung cancer, no chance of meaningful recovery, and languished in an intensive care unit for weeks. And that's what she didn't want. Now, if she didn't want that narrative, does that mean that she necessarily would not want a slightly but significantly different narrative, which is, you know what, we don't exactly know what's going on, but aggressive intervention might have some chance of helping you, and would you want it to be done in that situation? It's actually a significantly different narrative. Option B, highest technical quality. We can do it, we've got the tools, let's be aggressive. Let's try to save this patient's life because we don't know exactly what's going on tonight. If we save her life tonight, we might be able to figure out later the full picture of what's going on. And we're not really sure that what she meant was that she didn't want us to be aggressive in this particular situation. Option C, is there a bioethicist on call. As I said, the cases get a little bit trickier. I won't let you choose option C because we don't have a bioethicist on call at my hospital. So who goes for option A? A few, okay. Who goes for option B? Also a few, quite a few abstainers. Who is really, really glad that they don't work in critical care or emergency medicine? That's fair. I was being a little bit duplicitous because, in fact, that's exactly what we did. So that was a little bit, unfair of me. And so what we did is we went to the family, and I think one of the most difficult things to do is to go to the family and say, look, you know all that stuff that we told you before? Well, we're not so sure. And at this point, we were not so sure. It was not that we were sure that it was wrong. It was just that we were not so sure. So we went back to the family. That's absolutely an apropos question. And we went back to the family and said, look, I am terribly sorry. This is what I told you. There may be another possibility. We explained to them what we thought some of the other options in this story might be. We communicated honestly, openly, and we were very, very fortunate because they were not especially angry. I expected them to be furious. They were not. They were actually a lovely family who said, oh, okay, well, that's understandable, that sort of thing happens. If they had been the family in case 2, I think it might not have gone quite as well. And so then the patient looked a little bit different to all of us, to the family, and we asked, did she say more specifically what she would want in a particular set of circumstances? And they said, well, no, she didn't really. I mean, she just said that she wouldn't want to be in the same situation as her husband. And yes, we do see what you mean. This is not exactly the same situation. The family spoke about it for a few minutes, and our suggested course of treatment, if they wanted to do something, was that we put her on BiPAP, which is a pressure support type of measure, and we tried to put a tube in her chest to see if we could drain an amount of fluid, both of which they agreed that we should do, and both of which we did to very, very impressive effect. Her SATs started improving, her blood pressure came up, a large amount of pus drained out of her tube. After about an hour, she was able to squeeze someone's hand. And I felt that curious mix of emotions that can happen when the best possible thing has happened. Absolutely no thanks to me. And I thought, wow, I'm really glad I work in a place where A, someone figured out what I had missed, and B, they were courteous and professional enough to involve me in that in a meaningful way. And we were able to move forward with that. Now, remember I said that we always approach quality, and I don't know if we ever actually arrive or achieve at an ideal of quality. And to that, I'll tell you what happened in the next couple of weeks to this patient. I was very interested in the patient, and so I was following her on the computer system. Thankfully, we have something that sort of resembles an e-system in our hospital. And so I was following the case, and what happened was this. She was in the ICU on BiPAP for about a week, and she remained very sick. And they were they were not of a mind to intubate her. They were eventually able to wean her off BiPAP, but she had been on BiPAP for so long that she developed some very painful skin erosions around her face, which is really a terrible sort of thing. But nonetheless, the BiPAP kept her alive until her respiratory status improved to the point that she was able to be weaned. She went to the ward on oxygen and was there for about a week as well, able to speak to her family and interact with her family. By this time, the workup had revealed that she, in fact, had lung cancer just as her husband had. And she had not been a smoker, but likely as a result of secondhand smoke, she had also been stricken with lung cancer. After about a week on oxygen, she deteriorated, went back to the ICU on BiPAP once again, and by this point she had made it clear that she did not want to be intubated, and she knew her diagnosis, and then she died a few days later. So why am I telling you this? I guess the reason I'm telling you this is because there's a lot of different ways to look at this particular story. Did we do the right thing for her? I like to think that we did. I like to think that we gave her some time to properly say goodbye to her family. Now, you could look at it another way, and you could say, but did you really achieve that? She had not wished to be intervened with. If she were in her husband's situation, we did not know, in fact, that she was in her husband's situation. But if, in fact, we had proceeded with an incorrect diagnosis as our story, would we have done for her something closer to what she wanted in her story? It's a big question mark. And I don't have a particular resolution to that conundrum. But the reason I'm telling you about this case, which was a difficult case for me, is twofold. One is to say that I think that narrative often does help us to think about these difficult problems in a meaningful way, to figure out what we're going to do, whether it's someone who's cut their little eyebrow and otherwise looks charming and sweet, whether it's someone who's afraid of a test for an irrational reason, or whether it's someone who presents us with an undefined clinical scenario whose story we have to sort out. I think narrative and understanding of narrative is one of the only ways that we can get through those situations. And the other reason I'm telling you this is to say that despite the first thing I told you, I don't think we can ever claim that we'll always get where we want to go. But I think what we can do is try to get there and to try to understand the stories that patients bring to us and to try to discern what it is that we can best do within those narratives. We struggle with quality. We struggle with day-to-day care. We struggle with systemic quality issues, and we struggle with delivering the best quality care in situations that are often ambiguous and difficult, and we swim in murky waters. I really think that in many instances, we may be left with questions and doubts, and I would still put it to you that the highest quality way to navigate the murky waters is by entering the story of our patients. Sir William Osler, a great Canadian physician, left us with this thought. The practice of medicine is an art, not a trade, a calling, not a business, a calling in which your heart will be exercised equally with your head. Often the best part of your work will have nothing to do with potions and powders. Thank you.